With this, we move on to the last part of the scientific session before lunch, and that is debunking the myths of oral GLP-1, looking through the lens of an endocrinologist. To speak for this particular session, I would like to invite endocrinologist Dr. Awadhesh Kr Singh, and to chair this particular session, I would like to invite Professor Dr. Sujoy Ghosh and Dr. Arjun Boyddo. Both of them are endocrinologists. I request you, sir, to kindly be on stage, and I would like to invite Dr. Awadhesh Kr Singh, sir. Dr. Arjun Boyddo will not be there with us for this particular session. I would like to request Dr. Sanjay Shah, sir, if he can kindly be there as the chairperson.
The topic has already been introduced, and I don't think Dr. Singh needs any introduction to this audience.
Thank you, organizers. So I know we are just before the lunch, and everyone is suffering from hypoglycemia. Session is already running late. I will not waste time. But then the story of GLP-1 is always interesting. If you are really interested to know the update of this particular, few days back, there was a huge media uproar because of one research letter in JAMA, which claimed, this is an observational study from a US database, that, oh my God, don't use GLP-1, it increases intestinal obstruction, causes pancreatitis. And everyone in Twitter, in social media, was behind GLP-1. Oh my God, what a bad drug. Be careful when you are using. The next day, a breaking news came from the Novo Nordisk head office from Denmark, that a renal outcome trial called FLOW is a first renal outcome trial with GLP-1, has been stopped prematurely because of excess benefit in the renal endpoint against placebo with GLP-1. It is here injectable semaglutide. Everyone has started writing, my God, what a drug. Moral of the story is, this is what the science is all about. Be careful. A drug, as I said, roses have got thorn. Handle carefully, gives you the best smell, the queen of the flower. Handle carefully, it may have thorn. So today let's look at the oral semaglutide, some of the myths which is flowing across the board. So before you look at the myth, I thought to make a very clean agenda. Let's look at the merit first, then look at the myth, and look at the data behind this myth. I will not bore you. Simply, this is a busy slide, no need to read. We published quite a few papers on oral semaglutide, reviewed all the literature behind that. Remember, oral semaglutide, when it was launched, it is a costly drug. Everyone said, oh my God, 400 takar oshud ke likhbe. Do you know what is the current status? It is not being provided by Novo Nordisk because of such a rise in sell that they are not able to provide your patient oral semaglutide. The head office, the Denmark of Novo Nordisk, gives you that particular X number of pills to India. They are 2 times higher requirement in terms of X number of pills. They had said, I'm sorry, we are not able to provide. Now think, 2 years back when this drug was launched, we were thinking that who is going to write? They are not able to supply now the drug. This speaks volume about the popularity of the drug. And why there is a popularity? Because there is a merit. There are 10 trials done with oral semaglutide, of which the 8 is a multi-center, multi-centric trial, multi-country trial, of which I will concentrate on 3 trials. Very quickly, you know about that. There are 4 head-to-head trials done with oral semaglutide, starting from Pioneer 2, head-to-head fought with empagliflozin 25 milligram, Pioneer 3-7 head-on fought with sitagliptin 100 milligram, and Pioneer 4. It is interesting because Novo did a trial with their own product. So in Pioneer 4, oral semaglutide was, fought between injectable liraglutide. and that is in the highest dose of liraglutide 1.8 milligram. So let's look at this 4 head-to-head trial data and you learn the science, the merit of the drug. So you can see the blue bar, 4 trials, Pioneer 2, 3, 4, 7. And if you look at the active comparator, all our active comparator trial, the blue one is oral semaglutide, and heads on, it beats all 3 active comparator, oral sitagliptin 100 milligram, empagliflozin in the highest licensed dose 25 milligram, and Novo's own product, liraglutide 1.8 milligram, hands on in terms of HbA1c. If you look at the mean HbA1c drop across the trial, it was always more than 1%, sustained more than 1%. It's not like 0.5, 0.6 with DPP4 or 0.8, 0.7 with SGLT2. It was always more than 1%. Now, if you add body weight lowering part into this context, because GLP-1 is popular for reducing body weight, and if you look at these 4 trials, again, heads on, the oral semaglutide beats even liraglutide. So 2 GLP-1 fighting with each other, and look at the mean weight loss is nearly 5 kg across these 4 head-to-head trials. Now, if you combined both body weight as well as the HbA1c reduction, that is also in the tune of more than 1% body weight reduction and body weight of at least 3% weight loss. Again, if you see, the tallest building belongs to oral semaglutide. What was fascinating to note was it was superior to liraglutide. So this speaks volume about the oral drug that beats their counterpart, injectable liraglutide, every day. And on an average, if you look at the merit, the drug having a average HbA1c lowering of 1 to 1.5%, 5 kg weight loss, nearly as an antihypertensive drug BP reduction of 5 millimeter of mercury, and significant reduction of 5 centimeter of waist circumference. So where is the myth? What is the issue with that? There are certain myths which has come up in the past 2 years of this particular drug use, in particular in our part of the world. So first one is, this is a complex drug to use because everyone needs to get up, and you all know how this drug is given. You start with 3 milligram once daily, then you step up to 7 milligram in after 1 month, then you go to 14 milligram after 1 month. What is the problem? How is it complex? We did it with every drug for the diabetes, starting from let's say AGI, you started with Voglibos 0.3 milligram once daily, then we go to twice, then to thrice, so that the patient is able to tolerate the drug. If you look at the glimepiride, we started with 1 to 2 to 3 to 4 to 6. This is always a story with an anti-diabetic. What is the big deal? Knowing that the GLP-1 increases the GI side effect. It is the compliance that matters at the end of the day. So that was the classical way to use this drug, knowing that GLP-1 increases GI side effect. Now, there is nothing complex about that, and there is no need to think that this is a very complex regime. And as you all know, this has to be started with 3, 7 to 40. The next is whether it is challenging to the patient. Patient has to get up in the morning, had to take this medicine, have to wait for 30 minutes before taking any meal. What is the big deal about that? This is what you do for a thyroxine tablet. All your hypothyroid patient has to do similar thing. Indeed, for the thyroxine, you have to give at least a 40-45 minutes in duration of time before your patient eats anything after the thyroxine tablet. So what is big deal? The big deal was little bit the water you are consuming. For any drugs, you have got an unlimited amount of water you should take. But for oral semaglutide, you need to take this particular amount of water, which is half of the glass of the water, because in studies this has very complex mechanism in terms of their complexity of the drug binding with the snack. And if you give a lot of water with oral semaglutide, it reduces the bioavailability. If you give less water with the drug, it again increases the bioavailability, and so on and so forth. And therefore the only limitation is to say patient adhe glass jol khaben er beshi khaben. That's it. This is not a big deal for a revolutionary oral GLP-1 for the first time. And this is how you know this drug should be taken, and I'm not going into this detail. The third point is it better than the injectable semaglutide? Remember the SUSTAIN program with injectable semaglutide. the most powerful anti-diabetic ever made in terms of not only the GLP-1, but across the anti-diabetic class was injectable semaglutide. That was Ozempic, 1 milligram. Remember, Sustain 6 is one of the cardiovascular outcome trial which has a highest 3-point MACE reduction, which has got a highest stroke reduction by volume of 39%. It has never ever happened with any drug in the planet. And we thought that injectable semaglutide is the most powerful glucose lowering drug available to this. Now people are thinking whether oral semaglutide is equivalent to injectable semaglutide. When I am talking about injectable, I am talking about 1 milligram of semaglutide. Remember, semaglutide has got a different dose. For obesity, injectable semaglutide 2.4 milligram once weekly is approved, which is Wegovy. We are talking about Ozempic for diabetes approval. Now there is a study, this is a study from all the trials of oral semaglutide as well as Sustain program. This came from the Daniel Drucker lab, you know, one of the greatest scientists from Canada. And they looked into how, oral GLP-1 is matching with the injectable semaglutide 1 milligram. And they come to a conclusion that the 14 milligram of oral semaglutide is at par with injectable semaglutide 1 milligram. And this is how this data looked like. Now the second question is that if you have got injectable semaglutide available in India tomorrow, are we going to use injectable semaglutide once weekly versus oral semaglutide every day? And there is a controversy in this aspect. There are some studies actually looking into whether injectable once weekly is preferred over oral GLP-1 daily and vice versa. But however, in terms of patients, is always any oral drug is preferred over injectable drug. But if you look at the data, there is a little controversy. Majority actually preferred oral drug over injectable even once weekly, because this the injection which makes the drug little unpopular, and oral drug is preferred. The fifth question: does it work in our population, Asian population? Always when you are giving a lecture and someone will ask you, is there any study conducted from India? Do you have our own data? In the Pioneer trial, we don't have exact study, stratified into Indians or South Asian, but they looked into different race. And let me quickly tell you that in these trials, as you can see, white, you can see it as stratified into 3 race: white, blacks, African Americans, and Asians. And if I show you the evidence in terms of what happened to the Asian, you can see the right side of each column. For the Asian, HbA1c lowering was similar or sometimes better. In some of the trials, as you can see, HbA1c lowering was better with the Asian compared to their Western counterpart. So this data at least speaks that it doesn't matter which race you belong to, the drug works across the race. Then the sixth important part, that weight loss. How is the weight loss ability of oral semaglutide? Is it similar in terms of injectable semaglutide 1 milligram? We are not talking about anti-obesity drug injectable semaglutide Wegovy. Now, the theoretical point is that GLP-1 reduces body weight in this mechanism, and I'm running out of time, so just give you a quick look that this drug stimulates certain center in your hypothalamus and reduces hunger, and it also inhibits certain area in hypothalamus that increases satiety. So basically, if you are taking a GLP-1 agonist, you don't tend to eat much. It's very simple. Secondly, it increases the gastric emptying time, so therefore, if you have taken 1 meal, you don't wish to take frequent meal. Very simple, the funda mechanism behind how the weight loss happened with the GLP-1. So the next question is, how much is the GLP-1, in particular oral semaglutide weight loss in terms of, in comparison with injectable semaglutide? So recently we looked at this data. Now if you look at the ADA, US FDA's requirement to call any drug as an anti-obesity drug, the rule suggests that if any drug reduces body weight by 5%, you are an anti-obesity drug. So there is a 2 criteria of an anti-obesity drug. It has to follow the mean efficacy criteria or a categorical efficacy criteria. Mean efficacy means you have given the drug in 100 patients, everyone should lose 5%. You are an anti-obesity drug. Or 35% of patients in your trial, means out of 100, 35 should lose more than 5%, and it should be twice, compared to placebo. This is called categorical anti-obesity drug criteria. If you go by the FDA's anti-obesity drug criteria, you look at the weight loss of 5% with oral semaglutide. So when I'm talking about the highest dose, 14, or injectable semaglutide, 1 milligram, or liraglutide, you can see it has crossed the categorical efficacy criteria of US FDA requirement laid down in 2007. So this drug has a good potential to become an anti-obesity drug. And if you look at the 5% weight loss, it is better than liraglutide and similar to injectable semaglutide, that is Ozempic. We also looked at the 10% weight loss. You can see on the right-hand side, even the 10% weight loss is similar to injectable semaglutide. So that paper from the Daniel Ducker labs speaks that in terms of weight loss, oral semaglutide 14 milligram looks to be at par with injectable semaglutide 1 milligram. And this trial recently presented at ESD and at ADA, the Pioneer Plus trial. If you look in the Pioneer Plus trial, oral semaglutide 14 was compared to the higher strength. Remember, oral semaglutide in higher strength, 25 and 50 milligram is being brought out as an anti-obesity drug. How? This is a trial called Pioneer Plus, and there is another trial called Oasis 1, which was done in patients strictly with obesity without diabetes. And Pioneer Plus trial is a trial in patients with diabetes with obesity. Now, if you look oral semaglutide here, 14 milligram, which is available in our part of world, the mean weight loss was more than 5%. So by this criteria, they follow the FDA's mean criteria of anti-obesity drug. So that is fascinating, that oral semaglutide is not a very simple anti-diabetic drug. It has an anti-obesity huge potential. Very simple to suggest. Now, and if you look at this weight loss, this is predominantly because of fat mass loss, not the lean mass loss. There is always a concern that which kind of body weight loss happens. It is primarily the fat mass. The lean mass is minimal. Now, there was a controversy that you make it a sarcopenic obesity. But this year at ESD, with the Monjaro, tirzepatide, people looked into what kind of lean body mass is lost. So it is not the actual muscle mass, but muscle adipose tissue that has been lost, which was done through the PET scan and MRI, very recently presented at ESD for tirzepatide trials. Okay, and these are the data for the fat mass or the lean mass loss. Finally, what are the drugs which has got interaction? Nothing actually except thyroxine. You can see this. There are PK/PD study done with oral semaglutide. Nothing is significant, barring that if you are using levothyroxine, you should be careful because oral semaglutide increases the availability of thyroxine by 33%. So if someone is a hypothyroid and also having obesity or diabetes, you wish to use oral semaglutide, how to use levothyroxine? Either you should give it after 30 minutes of oral semaglutide, or you give it at the night time, at least with a 3-hour gap after the dinner. This is how we use levothyroxine with oral semaglutide. So these are some considerations for oral semaglutide. There is no issue whatsoever with PPI. So if somebody is taking PPI in the morning, and there is no problem whatsoever. Finally, you don't need to reduce the dose in patients with liver or kidney disease. As you can see here, you don't need to reduce the dose. That's one beauty with the oral GLP-1. Remember, indeed, even for the injectable GLP-1, you have got a EGFR cutoff of 15. For oral GLP-1, you can use in any drug. But be careful in patients with CKD because of GI side effect. Now, let's come to the side effect. And this question was often raised, that is there any possibility of retinopathy increase with oral semaglutide, which was seen with injectable semaglutide. Remember in SUSTAIN 6, in the cardiovascular outcome trial with injectable semaglutide, there is no such data with oral semaglutide. Across the 8 multinational, multi-country trial of Pioneer, there was no signal whatsoever of increase in retinopathy with oral semaglutide. And if you look at the current ADA standard, they did mention that there is no issue with oral semaglutide. Even with injectable semaglutide 1 milligram, it is nothing directly related to the drug, but it could be due to massive drop in the HbA1c, as we learned in the DCCT trial. So ladies and gentlemen, to take you through this oral semaglutide, there was a lot of noise from the cost. And as I said, now the company is not able to provide the drug. This is how the so-called our poor people is not affording the drug because of the benefit we saw. There is always a, tides behind going on with GLP-1. Someday people come with increase in pancreatitis, some other day with intestinal obstruction. Other day you come up with the data that this reduces cardiovascular risk reduction. The drug has a potential to protect kidney. At any point of time, the benefit with GLP-1 always exceed any risk whatsoever. That's the simple story. If you have got a patient who needs GLP-1, remember the GLP-1 and SGLT2 is currently the first line drug in patients with type 2 diabetes with more than one cardiovascular risk factor. Of course, these are the drug of choice in people with CKD, heart failure or established cardiovascular disease. But even if the patient doesn't have heart disease, heart failure or kidney disease, if you have got a type 2 diabetes with any one risk factor, the current ESC guidelines recommends you to use either SGLT2 or GLP-1 RA. Thank you very much for your patience listening.
Big hand. Thank you for that lovely presentation, Dr. Awadhesh Singh. So before somebody asks questions from the floor, we are now fascinated with all that data that comes from GLP-1, particularly semaglutide. So at a practical level, at what BMI, if there is any, at which you perhaps don't want to prescribe SEMA?
Don't want
to prescribe SEMA.
Well, so...
if there is any.
Right. So, look, we are not using GLP-1 only for the BMI context. Please remember, even for the SGLT2 for that matter. So if someone has got established heart disease, heart failure, CKD, you don't need to look at the BMI. Go for the GLP-1 or SGLT2. Now, if patient do not have established cardiovascular disease, heart failure, CKD, then your question comes into picture. If you look at the current ADHD guideline, their left-hand side picture is related to body weight. Now, there is no exact nature of the BMI cutoff where you should not use, but if you look at the pioneer trials or for that matter CB outcome trials with GLP-1, they excluded the BMI of less than 18 in their trials. So, I should be reasonably fair to tell you that if someone has got a lean BMI, you may not afford to use, provided the patient do not have established heart disease. So even if someone is a lean with established cardiovascular disease, you are mandated to use a GLP-1 or SGLT2, regardless of the BMI.
So are there patients with low BMI included in the trials?
In the CB outcome trials,
yeah.
Yes,
yeah.
But not in their phase 3 program.
Thank you.
Please.
You see, I am not a diabetologist, I am a gastroenterologist. My only question is, in oral semaglutide trial, what percentage of patients dropped out because of side effects? The reason I'm asking is, most of the patients I see, I have a jaundiced view. Most of the patients who come to see me who are on semaglutide are because of GI side effects.
Yes. So the GI side effect is a known side effect of GLP. This is how the drug works. Now, if you look at the dropout, in the GLP-1 trials, it varied from 20 to 25%, quite a high dropout number of in the GLP-1 trials. Maybe even in the real world scenario, you might find even higher. So, someone is not able to tolerate is a different story altogether. So, I mean, the drug acceptance in terms of GI side effect is of course poor. This is the most common, reason for not continuing with the drug. Barring that, those who have suited, those who have lost the weight, those who have lost the HbA1c to the required target, they are still continuing with the drug. So yes, if you ask me frankly, perhaps 1/4 patient do not tolerate the drug. So that's, my own experience, and I'm sure Satyanath and everyone in this hall will agree.
Whether the weight loss is universal with SEMA, in my practice I see at least 10% of the patient do not lose even 1 kilogram of weight.
Right, it happens with everyone, even with the anti-obesity drug. Look at the Mounjaro trial. No, not everyone lost the drug. So now means what amount of weight loss, that's the important. Someone, for example, if you look at the triple and agonist now, GLP-1, GIP and glucagon, retatrutide, 100% of the patient has more than 5% weight loss. Now if you are saying that patient did not lose weight, means what weight loss you are asking about? Anyone who lose 3% of weight, this is significant enough to reduce the comorbidities out of obesity. Now you say that, okay, someone was 100 kg and he didn't lose weight by even 1 kg, means there is a non-responder. And there is always a non-responder with any drug in this planet. So I agree with you, there are some patients who do not lose. Then this drug is not a great in terms of weighting loose for that particular patient.
Right, I think we're running out of time. Okay, a big hand to again Dr. Awadhesh Singh.
Thank you,
for a
thank
lovely
you.
lecture.
Thank you,
And we move on to the next session.
Thank you, sir. Thank you, speaker, sir, and chairpersons.
Lamplighting. No?
Yes, sir. Sir, before that, I would request you to kindly felicitate Dr. Awadhesh Kr Singh.